I'm now excited to bring up and introduce Dr. Nicole Perez. She's a licensed clinical psychologist. She's come to us from West Tennessee, I went to the wrong part of the state. East Tennessee, Knoxville, with the University of Tennessee. She completed her internship in behavioral medicine at the Medical University of South Carolina, and then her postdoctoral fellowship with the American Psychoanalytic Association. That sounds pretty impressive to me. She's now assistant professor in the Graduate School of Medicine, and she runs the nursing wellness program at the University of Tennessee Medical Center. She's also part of their pastoral care department and holds a private practice. So she's a busy lady. She specializes working with long-term treatment and assessment of children, adults, and adolescents. So if you would join me in welcoming her to the podium.
Good morning. I am exhausted just hearing all of that. Makes me want to take a vacation. This is going to be a little bit constraining for me, but I'm a loudspeaker, so if you guys can't hear me as I kind of move around, just let me know. Let me explain where I'm coming from here. Ending up at the University of Tennessee Medical Center is an interesting path for a clinical psychologist. It was certainly an interesting path for me when I went to training. One of the things that I trained to do was you sit in a room, you dim the lights, you have a patient right in front of you. I'm mostly psychoanalytically trained, so my fantasy would be that I would have this laid-back couch, I would do analysis, and it would be all fantastic. Well, how mistaken was I? While I was a student, I decided that I wanted to do an innovative internship, and pastoral care department at the University of Tennessee Medical Center had this vision, which I have no idea why no one had thought about it before, of having a clinical psychology intern and resident inside the emergency room. So I said, sure, I'll do that, which turned out to be a really stupid idea at the time. They threw me into the emergency room, and there I was by myself, 365 days on call. In fact, my husband would just nudge at me if he heard the helicopter going towards the hospital, came over my house. I'd just roll out of bed. By the time that I parked in the ED, the pager would go off. And it would be for really silly things, like our patient Luella, who would sing at the top of her lungs, Amazing Grace, and you could hear her down the hallway. And she would get louder and louder every time that someone got near her with a needle. And they'd call me in and they'd say, she's driving everybody nuts. Okay. I'd walk straight to the water fountain, get a glass of water, hand it to Luella, and she'd stop singing. And people would say, wow, this is like magic. You're like awesome. And I'm going, well, she can't sing and drink water at the same time. There's a lot of limited understanding of mental health in our community in general. And one of the things that I want to make sure is that we understand how complicated these things are when we talk about NAS families. And I also want you guys to understand how complicated it is to work in interdisciplinary settings and collaborate with each other in ways that make sense. So this is a wonderful group of people because we have people from the nursing department, and we have people in social work, and we have people in the addiction industry and physicians. And so one of the things that I want to drive home today is that we might have gotten into these careers thinking this is what I'm going to do. But the truth is, if we're going to make an impact with some of these very complicated issues, the best education you can get in here today is looking around you and seeing that it takes a village to manage these mental health issues. So it's really important that you guys make connections here today. So this comes from a nursing wellness perspective, mostly because I gave this talk at UT for my nursing wellness training. And I know that there are people here who are not nurses. So we'll try to make it general for everybody, but this applies to you as much as it applies to anyone else. So let's try to do this without moving around too much. let's see if I can do this. So as I said, we're going to understand addiction and related disorders. We're going to talk about psychological development and attachment in infants, and we're going to talk about strategies of care with NAS infants and families. So let's understand substance abuse and addiction. Psychology has a diagnostic and statistical manual of mental health disorders. We have a new one. It's called the DSM-5. Thank you to all of you physicians who have made us collaborate with the ICD-10. Now we can get like 20 diagnoses in one axis, but I know that you guys are struggling more than we are in terms of doing that. We have 10 classes of drugs. We have alcohol, caffeine, marijuana, hallucinogens, inhalants, opiates, sedatives, hypnotics, anxiolytics, stimulants, tobacco, and whatever else is unknown that people may abuse. Glue, whatever it is. Activation of the reward system. We talked about this morning in the earlier presentation. Basically, this is like getting a treat. It's fantastic. And anyone who went to college in here and experimented a little bit knows that it was fantastic. So the reward system basically feels good. This even happens with anorexia. In fact, one of the things that happens with bulimia and anorexia, bulimia in particular, is that every time that people throw up, there's a rush that happens in the brain. And it brings up your endorphins. So it feels good to throw up. Can't possibly imagine, right? Because anyone who's been drunk over the toilet goes, I will never drink again. But there's actually a rush that goes on in the brain when we activate this reward system. There's a change in the neurological circuits, which we're talking about the pathways that happen, and that is beyond detoxification. So once there's a change, it's like this water hose metaphor. Something gets carved, and unless the situation changes, we're bound to go back and repeat and repeat and repeat. So it takes time to rewire the brain again. Behavioral addictions are just as significant as substance addictions. And we'll talk about that more when I talk about attachment theory as to how significant they can be for infants. But in terms of NAS in particular, we're talking about chemical addictions. So we'll keep that in mind as we move forward. Ages 18 to 24 have higher prevalence rates. Why is that? Why is that? Because we're in college. And we drink in college. And if you're not drinking, there's probably something wrong with you. You're going to be in my office uptight later with an anxiety disorder. So there's higher prevalence rates. Intoxication is always an initial diagnosis. There's abuse versus dependence and how pervasive it becomes, then how much of a problem it becomes in the future. So we tend to watch it. The DSM-5 has done us the horrible change of telling us that there is no difference between abuse and dependence, and that we diagnose these things from mild, moderate, and severe. So that's kind of an interesting thing. So, Dr. Patrick, you work with residents. Okay. Residents, research says, we have to increase the drinks that they take in one day by 50% before we can consider that there's a drinking problem. Are you aware of that?
No.
Okay. Yes, good. I saw the flask you're carrying in your pocket, man. Now, this is a problem, right? Because it's become so popular for us to drink and overuse substances. So it's kind of a tricky thing to figure out who has a problem and who doesn't have a problem. With my residents, we're talking about them at the end of the week, debriefing, or they go home and they have a glass of wine, 2, 3, 4, 5, 6. And so the rates of how I measure this in the clinical room becomes complicated. If I have a resident that walks into my office and says, Dr. Perez, you know, I'm doing this and that, and I'm trying to gauge their drinking, we're trying to figure out, okay, well, is 5 too much for this person? It's funny, we come up with some strict kind of ways of looking at alcohol abuse or looking at other use of drugs, and we're trying to figure out what is really a concern for us. So a lot has changed with this. A lot has changed with marijuana use. So it's being used for epilepsy in children. So what are the benefits? At what point it does not become beneficial? How do we talk about these problems that we, in some states, state of Tennessee is illegal to use marijuana, but a couple of states next door, it's not. So how do you begin to talk to these populations in a way that it makes sense? It's really important to think about that. Freud, I mean, we were talking about the 1980s, right? Where we were talking about some of these things were in all the medicines, or in the 1940s, or what about Freud thought cocaine was a miracle. And it was used consistently for a long time, that it was just a miracle for mental health issues, pain management in particular. He was a neurologist by training. So trying to gauge what we're really dealing here psychologically is a really interesting thing when we talk about treatment. We have categorizations in early remission and sustained remission, on maintenance therapy in a controlled environment, tons of subcategories as to how we're going to deal with these things. So my point being, addiction is complex. Not every addict is the same as every other addict. Not every person who uses pain medicine and maybe overuses pain medicine is an addict. So it's really important to try to figure out on a case-by-case as what we're dealing with. However, if we do determine that there is an addiction, odds are that there's a lifelong prevalence. We're talking about a pervasive condition that is chronic, like managing diabetes, for example, and to some extent or the other, I have to always monitor that this person has a vulnerability for relapse or for misuse of medications. So as a psychologist who is not prescribing the meds, and I'm collaborating with an internist or a primary care physician or a neurologist, and we're all over the place, it is my responsibility to try to make sure that my colleagues understand what we're dealing with. If I send someone to a psychiatrist, I should say, all right, FYI, you know, they have a history about 5 years ago about abusing these kinds of medications. Let's just be cautious, because it's really important that we understand that these things can be lifelong. There's challenges in comorbidity. I have never seen an addiction case that does not have other psychological issues involved with it. Addiction does not live in a vacuum. So there's different philosophies, right? It's interesting, we talk about the medical model where we think about this as a disease. In the psychological realm, when we're sitting as a clinician in a room, we're also thinking about, all right, chicken or the egg, chicken or the egg, chicken or the egg. Is this person using drugs because they were inherently unable to cope, and this is what they've done, and eventually it turns into a disease because they're dependent on this and it rewires everything in their brain? Or is it the other way around? It's hard to tell. We don't know. But most of the times, there be 1, 2, 3, 4, 5 disorders that we're dealing with. And oftentimes, we find that they're misdiagnosed, poorly treated, 20 medications. There's nothing more interesting than going into an emergency room and someone's telling me that person has a mental health issue, and you open the chart. And they're on 3 antipsychotics, 1 stimulant, 1 anxiety medication, 2 antidepressants, 3, and you're thinking, what the hell? I mean, what happened here? You know what happened? We don't pick up the phone. We like to stay in our little niche, right? And we don't pick up the phone, and we don't call the doctor who's treating this person, and we don't communicate with each other. That's what happens. So they go over here, and this person says, oh, you're anxious? Okay, well, forget that you're on 3 mood stabilizers. Let me just give you some Prozac. And it keeps adding on, and contradicting what they're doing. So we have to understand that this stuff requires more than one person for care. You may be the person who's dealing with the addiction of this person. There also should be a person dealing with something that has to do with the mood disorder who's an expert in that area, or whatever other disorder that they have. And there should also be a physician who's managing the medication. I know we want to fix it all, but we can't fix it all. That's the whole point of a village. When people have other mood disorders, we're going to have some further complications. We have increased mood liability coupled by a lack of insight. Most psychological disorders have lack of insight as a secondary variable. Why? Because when I'm anxious, is that a good time for me to make a decision? Probably it's important for the crisis to be over before I can make a decision, right? If I am going through a manic state, is that a good time for me to make a decision? No. Limits in reality testing and the way that I self-observe myself. If I have a psychological disorder, whatever it might be, do I spend a lot of time looking at my garbage inside? Why not? Why don't I do that? Because it hurts. Because it's painful. Medication management is a challenge. Do you think I'll comply with my medicines if I have a mood disorder? If I'm depressed and I can't get out of bed, will I remember to take my medicine? Probably not. Funniest thing is when we have these crisis emergency lines, I'm not saying they're not useful, but we expect a depressed person to pick up the phone and go, hello, I would like to have a therapist. Oh, yes, yes. I'm going to give you another 800 number, and you call that number. And then you call and you get a voicemail. And you're going like, okay, let me leave this voicemail. And then they go, you should call your insurance and see how much is covered by this. This is a depressed person, for crying out loud. So there's also a system issue in trying to get the resources that we need. So remembering something as basic as your medication, which I just remembered I didn't take this morning, it's probably important that we understand that this is a challenge. Self-medicating usually increases symptoms. So we have this thing of, what's making it worse? What's making it worse? Where do I intervene? There's a limited social support system. Why do addicts have a limited support system? Because the last time that you were at my house, you rifled through my purse, took my Visa, and went on a shopping spree. So am I going to have you over again? Probably not. So they lose their social support system slowly but surely. And that is assuming that they had one to begin with. Maybe they didn't have one to begin with, which is very likely. Poor judgment and impulsivity, not only because that comes from drug use, it also comes from poor mental health issues, rigidity in self and other perceptions. So this is how they think, right? Because I don't have much insight. I don't observe myself very well. I'm anxious. Now I'm high. So my judgments is not going to be quite there, and I'm going to be kind of rigid of how I see the world. These are called prejudices. So nurses in here, when you walk into a room of a mother who has addiction problems and has just given birth to their child, what is the expected initial reaction to you? Come on. It's terrifying. Why is it terrifying? What is my stereotype of you? I'm going to be judged, and I'm going to take your baby away. So you're already starting from a point of disadvantage, because the moment that you walk into that room, what's going to end up happening, oh, they can't see.
Yeah, it keeps cutting out.
Again, they're blind. So the moment that you walk into that room, you're already starting from a point of disadvantage, because they think that that's what you're going to do. And guess what? You have judgments about them too. What is your judgment? Who's willing to throw themselves in the middle and admit that they make judgments about people that they help? Oh, please, not all at the same time.
How could she do this to her baby?
How could she do this to her baby? What trauma have they been to get to this point? That's kind of a nice one. How long have you been in nursing? 35 years. I don't know what to do. How do I reach this person? I have no idea what to do, because the first thing that they're going is like, all right, you're going to take my baby away. You start asking questions that are in the protocol. they are accusatory to begin with. And they're sitting there going like, okay, you're telling me you're not going to take my baby away, but you're just asking me all these questions, and I'm kind of incriminating myself. I mean, before I know it, the police is going to arrive and they're going to take my child away. So yeah, how do you even talk to this person without them being defended? Treatment availability and compliance is a huge issue. Let's be honest. It costs a ton of money to walk in through my door in my private practice. And it takes people of vocation to really go to a mental health community center and do that kind of work. So it's really tough to find good care. And if I call Cherokee Health Systems in Knoxville, you have something comparable here, I'm sure. On average, how long will it take me to get an appointment? 60 days. Let me just hold this thought about jumping off the bridge for 60 days. And then when I get there, the job is I'm going to see as many patients as I can see, so the next time I can give you a follow-up for a chronic mental health issue is how many weeks apart? 6 to 8. Unless you have the moolah, right? If you have the moolah, you get to go to California and sit with Lindsay Lohan, I guess. What to expect? Every addict is unique. Common symptoms are secretiveness and attempts to hide the extent of the problems for a good reason. You are a threat to them. They have never trusted anyone in their lives to begin with. They have never gotten consistency in their life to begin with. So you're a threat to them. Lose interest in activities they used to like, substance or behavior focus, lying and unethical behavior, defensiveness, financial problems, criminal records, and vocational problems. So just take all of this and then let's say, all right, let me think about what the right treatment is for you. Can they get it? No. So we have to be honest about what we're dealing here. We are already dealing with some limitations from the beginning. So as health care providers, as people who work with this population, we have to come to accept those limitations and try to figure where we can actually make an impact. So when I talk about people making therapeutic progress in my therapy room, people may think, it's interesting when I say that if someone comes in suicidal and with a huge amount of trauma, and if I can get them from there to be depressed for the rest of their lives, and I say that that's the best that it's going to get, that usually gets a room up in arms. They go, really? That's the best that you can do? Well, guess what? Sometimes things are broken, and that's the best that I can do. And it's better to live depressed than suicidal. Or it's better to live vocationally but not be able to have relationships. We have to find where we can intervene to make it better. But that may not mean perfect. In fact, I'll save you the suspense. In this population, it'll never be perfect. Relational problems, hygiene and grooming problems, we're getting down to the bottom of the barrel. Worse, persistence, unexplained disappearances, mood swings, psychological problems, depression, suicidal thoughts, etc. Severe symptoms, while intoxicated or not, could be paranoia, slurred speech, inability to concentrate, blackouts, memory loss, manic behaviors, excessive talking, fidgeting, can't sit still, illogical thinking, hallucinations or delusions, accident-prone or clumsiness, withdrawal symptoms, frequently ill from the previous night, and easily agitated. Treatment and management, we know what the options are. Inpatient detoxification treatment, 12-step programs, which are statistically supported but don't address comorbid disorders often. We're just going to focus on this part. Addiction-specific individual and or group therapy, individual psychotherapy and or counseling, social work and case management interventions, and medication management. You know what the best treatment for addiction is? from all of those up there? It's option D, all of the above. That's the one that will have the more success. So we already look at what we're dealing with, because this is when it's going to have the most success. And unfortunately, not all of these are available to these people. They're also not, and if they are, they may not be together. It may be that you get this part here, and I had 2 years ago, I saw a counselor, can't quite remember her name. Maybe it was Lisa, Martha, I don't know. I can't remember her name. So it's important to think about these limitations. Other limitations for prognosis, compliance, mental health comorbidity, finances, availability, waiting list and frequency, social stigma, limited social support, resistance, and psychological conflicts, psychosocial conflicts like transportation, shift work, legal problems. So we get how complex this is, right? And frustrating. So let's talk about attachment. This is the part that really concerns us in terms of what we can possibly start to do, since the traditional ways of treating things are going to be limiting for us. Attachment is a close emotional tie between two people that keeps them united over space and across time. For normal social and emotional development, infants need to develop a relationship with at least one primary caregiver who is sensitive and responsive, because they respond promptly, appropriately, and consistently. So, I said one primary caregiver. Does that mean mom or dad? Is it better if it's mom or dad? Actually, it doesn't make a difference, as long as you are sensitive and responsive. By the way, this leaving the baby in the crib crying until it stops crying because otherwise it gets spoiled. Stop ordering self-help books from Amazon. So it's really important to be sensitive and responsive, and it doesn't matter who the primary caregiver is. It's just someone that has the capacity to be receptive and responsive. Do something. Take a piece of paper, turn one of my packets around, and if you have a pencil or a pen, if not, just think about this. We're going to do an early memories inventory in here. I want you to write down or think about what your first memory is. What is your first memory? I don't care if it's your actual first memory or if you think that your parents told you this and you're not sure. It doesn't matter. Just what comes to mind in terms of your first memory. Now I want you to think about what is the first memory you have with your mother or father. I want you to write down or think about what is your first memory of feeling warm and snug. Now I want you to think about and write down if you had a blanket or a stuffed animal. And what is your first memory of this? This is a gauge. Your first memory tells us something about what you had or didn't have as an infant during those formative years. Your first memory with your mother or father tells me about that primary caretaker that you first identified as a caretaker. Sometimes people go, well, I don't quite remember anything really about my mom or my dad, but I remember my grandmother. Or I had this neighbor. I remember that neighbor of mine. She used to make me these cookies. Or she used to come over at the end of the day. First memory of feeling warm and snug. That's safe. Like the green blanket that Corny had. And this transitional object tells us what is your inherent capacity to form bonds. We attach to things. That's normal. We're supposed to attach to things. If someone comes into my office and they tell me, I remember, I didn't do any of that. I didn't suck my thumb. I didn't have a pacifier. I didn't have a blanket. I didn't have a teddy bear or anything like that. I usually go, oh, goodness gracious. You must be the most anxious, anal, retentive, difficult person to live with. So what's more important? Feeding, house, home, a cave, or the teddy bear? Well, let's see. We're going to talk about Harlow's monkey experiment.
Conquest. The search for new knowledge about our universe, our world, and ourselves. This monkey is an orphan, separated from his mother since the day of his birth. Literally, his life hangs by a thread, a soft cheesecloth pad that is his only companion, his only comfort. Once a day, the pad is removed for cleaning.
This is the laboratory of psychologist Harry Harlow.
Troubled, distressed, permanently deprived.
He is studying monkeys to better understand human relationships.
He may die for want of love.
Harlow believes he can use science to study love. With a series of pioneering experiments, he explores territory where few scientists have ventured.
Harlows said that there was such a thing as a science of love, for example, that love, the kind of intimacy that characterized relationships between mothers and infants, although in his case he studied monkeys, could be the object of science, that you literally could move love into a laboratory, put it under a microscope.
Harlow is studying love because he believes it makes an indelible impact on a young life. The relationship between a mother and her child, what Harlow calls our earliest social environment, could hold the key to explaining behavior throughout life. Harlow designs a set of ingenious experiments. He raises a baby monkey, allowing it to choose between two surrogate mothers, a wire mother that feeds it, and a cloth mother that doesn't. A cloth mother that Harlow thinks might provide something else: comfort and love.
Here's baby 106, weaned on a wire mother. He's going to the wire mother.
But this infant quickly runs to the cloth mother, where he will stay for the next 18 hours cuddling. In Harlow's mind, choosing nurturing over sustenance. In another experiment, Harlow creates a fearful situation. Whom does the infant turn to now?
Let's find out what his reactions to his mother are when we frighten him. He's scared, all right. And he does what any child will do in a similar situation. He was running to his mother, to touch her, to drive away his fear.
To Harlow, there is something about the experience of comfort and love, even more than food, that seems crucial to all these monkeys. But what happens when the infant is raised alone, without any mother at all, wire or cloth? In this situation, the orphan monkey stays alone. He won't even go to the cloth mother when frightened, but retreats into his own world. Harlow believes he has shown how want of love can damage an infant for life, and he worries the same is true for people.
What comes through loud and clear in Harry Harlow's experiment was that the early experience and the environment were crucial to the healthy development of the infant child, and that in a sense, if you messed up, If the right kind of maternal presence was not there during the critical years, then that infant might grow up to be an adult incapable of forming healthy relationships with other kinds of people.
So the hypothesis was that attachment to its mother was based on feeding, but that the infant monkey would prefer and become attached to the cloth monkey. We're talking about nature over sustenance. So you see that the monkey's kind of picking at the nose of the cloth mother. He's looking for the food, but in the end, if it has to make a choice, it will take the nurturing over the substance. So it's a really important finding to think about that when we're thinking about how we're going to intervene with the children from these mothers who have these addiction problems. Why care about attachment? Well, substantial research links attachment to overall adjustment, social skills and competence, peer status, popular, neglected, or rejected, prevention of behavioral problems, cognitive development, formation of identity, physical health, and adult relationships. Many psychological disorders are related to insecure attachment, separation anxiety, RAD. Anyone been exposed here to a child with RAD? Yes. Failure to thrive, feeding and sleep disorders, depression, anxiety, aggression, developmental delays. All these things are really important to think about when we're talking about attachment. The stages of infant attachment. We have some sensitive periods for attachments between 6 months and 2 years of age. So you who are intervening with a child from really early on, you have to figure out where are they in their attachment and where do I need to start. Just because a child is 14 to 18 months old, that doesn't mean that they don't need to repair something from 1st to 8 weeks. So it's important to think where we are developmentally in the attachment of a child. That's different than the cognitive development, and the intellectual development, and the achievement. So it's important to think about this. 1st to 8 weeks, infants smile, they babble, they cry indiscriminately to attract attention and to communicate when they need something. There's no preference. Basically, they don't care who gives it to them. They just need to get it. That's it. You're kind of irrelevant. Don't worry, it comes full circle in adolescence. 2 to 6 months, babies are able to discriminate between familiar and unfamiliar adults. So they start getting used to people. They kind of walk into the room and are always present. They show an increased responsiveness to the primary caregiver, prefers him or her, follows him or her, clings to him or her. They direct attachment behaviors towards one particular person. This is when they pick. And who are they going to pick? The most consistent and reliable person. That's who they're going to pick. There's a hierarchy of relationships, and it's best to have fewer caregivers than more caregivers. Why? So they can use to consistency, which is really important. 6 to 8 months to 14 to 18 months, babies will protest separation, greet the caregiver, and cling to the caregiver when they're afraid, separation anxiety. Meaning that they know who that caregiver is, and they'll get anxious if that caregiver is gone. So what does that tell us about treatment? If you're going to get involved with a child between 6 to 8 months to 14 to 18 months, you better think about it. You better get involved with the institution or help them attach to the institution as a whole. Because what happens if you disappear? It hurts. Already. They may look to the caregiver to see how to respond to a new, ambiguous person. Basically, they do that social referencing. You're beginning to be a mirror for that child so they can learn how to interact with the environment. By 8 to 10 months, until 2 years old, stranger anxiety. This is when they have already known, this is my village. Now I know that people that are not in this village, I don't know about them. I'm not sure who they are. And I'm not sure if they're safe. After the second years, toddlers understand the caregiver is a separate person. You know, when they kind of stand in front of the mirror and they go like, and then all of a sudden they go like, that's when they finally begin to notice that, you know, me, you, we're different people. They cry to get attention. They cry louder. They may even shriek or shout. They use caregivers as secure base to venture out and explore, but will retreat to the caregiver when he or she perceives threat. 3 to 5 years old, kids will negotiate and bargain with caregivers about separation. They won't be as distressed as long as they know that you're going to be there. As long as I know you take me to childcare, and at the end of the day, has anyone had a kid melt down before because you're 15 minutes late? This is why. They have to make sure that there's a clear plan. And if you make a plan with them, it's better to say, I'm going to be here between 5 and 5:30, so they don't flip out. Because the moment that it's 5:31, they're going to go like, oh no, the plan failed. I will die now. They won't be as distressed if they agree on a plan for separation and reunion. 7 to 11 years old, it's not about proximity, but availability. They can be okay with longer separations as long as there's frequent contact and the parent is available if needed. This is a movement towards independence and individuation. So they want to call you on the phone. Mom, Dad, Mom, Dad, Mom, Dad. And you think that they're just being annoying because you have to do everything for them. And what they're really making sure is that you're there, you're available. I can go the whole day and stay at my friend's house, but I want to know that you're available. Then adolescence. Attachment shifts to peers. The role of parents is to be available if and when needed. Sad, huh? When you really say they don't care about me right now, you're absolutely right. They don't care about you right now. Moms will come into my therapy room going like, oh my God, they have no perception of me even existing. And I'm going, yeah, that's right. Sucks to be you. Nothing to say about that except that it's healthy development and you're going to have to put up with it. This has consequences to adult attachment styles. Securely attached adults, positive view of self, partner, and relationships, a good balance of intimacy and independence. Anxious, preoccupied adults seek high levels of intimacy, approval, and responsiveness from partners, becoming overly dependent, less trusting, less positive view of self and partner, and may exhibit high levels of emotional expressiveness, worry, and impulsiveness in their relationships. So, ladies and gentlemen, if it's a habit to check your partner's phone, I'm going to suggest that this is diagnostic. You may want to think about your attachment. Dismissive, avoidant adults desire a high level of independence, may avoid attachment altogether because they're super scared, view self as self-sufficient, no, I don't need anybody, invulnerable to attachment feelings and not needing close relationships at all, I can do everything myself, tend to suppress their feelings, dealing with rejection by distancing themselves from others. So let's look at dismissive, avoidant adults. If you meet a dismissive, avoidant adult, what assumption can you make about their infant attachment? Non-existent. Or at least very, very, very unreliable. Fearful, avoidant adults have mixed feelings about close relationship, both desiring and feeling uncomfortable with emotional closeness, tend to mistrust their partners and view themselves as unworthy, tend to seek less intimacy, and may suppress their feelings. So, it's really important to think about attachment when we're doing these interventions. It's really important to understand that some of the people that you're seeing that are the mothers, if you're on the other side of the adult spectrum, if you're beginning to see that they have problems with attachments with their infants, that means that they had attachment problems themselves. So where do I intervene? What do they need? Do they know how to sustain a relationship? If they stop using drugs, would that mean that they will all of a sudden become attached mothers? Probably not. So we have to tend to these things simultaneously. Important aspects of attachment for NAS infants, the influencing factors within a child, their temperament, their reactivity, and their self-regulation capacities. medical conditions, premature birth defects, illnesses, psychological conditions, autism, etc., all related to these drug-addicted babies. Within the caregiver, critical, rejecting, overbearing, abusive, neglectful, active psychological illness, addiction, personal problems, loss, grief, ignorance, goodness of fit, prolonged absences. This is what we can expect. And on top of it, we're supposed to remain compassionate and empathic. I'm supposed to understand this, right? But they're basically unbearable, unlikable people that constantly make me angry. What a challenge, right? Environmental, fear, pain, chaotic environments, domestic violence, community violence, war zones, refugees, institutionalization. How is attachment different for NAS babies? Not optimal psychological and health problems. They already start from an addiction perspective. They have limited social support. They have environmental inconsistency, inadequate living situations, many other challenges. So when I'm dealing with people who come from these environments, basically what we're trying to do is figure out how far I can get them up the spectrum. So let's go back to this slide where we have the adult attachment issues, right? I may not be able to get you to be a securely attached adult, but I'd rather have you be a dismissant, avoidant adult. At the very least, you'll be very efficient and successful, and you won't need anybody. So I'm trying to get you to a place with intervention that is possible when we're already starting at the bottom of the barrel. Which is frustrating, I know, but we have to understand our limitations. So we always have to think about the severity of the problem based on the drug use, overall health problems, poor intrauterine growth, premature birth, seizures, birth defects. I'm sure you will hear about this later from the physicians in the room. Withdrawal symptoms, tremors, excessive crying, irritability, high-pitched crying. Anyone who's taken care of these babies in a NICU know how complicated this is and how much energy it takes. Hyperactive reflexes, sensory sensitivity, light, sound, touch. It all matters. How you move in that room. Even if they're kids that have been through this and you're treating them later on when they're 6, how you move in the room, how fast you move. I have a patient with attachment issues who is 41 in my office. And the first time I got up in my office to get a book that is in a bookshelf right to her left, and she's sitting in the room, she climbed up the couch and said, "Don't touch me." She thought I was going to come towards her and touch her. So we have to understand that this is important from inception. Also, how we move, how we talk, what tone we use, how we communicate, how we soothe. All of these things are very important. They're coming from the outside. They have yawning, stuffy nose and sneezing, poor feeding, and stuck development, not suck development, but, you know, Freudian slip. Vomiting, diarrhea, dehydration, sweating, fever, unstable temperature, and others. So attachment is always possible. Here's the good news. Consider single parents, homosexual couples, adoptive parents, foster care, other. Because what is important here? Consistency and responsiveness. So attachment is always possible to some degree or the other. Helpful attachment factors, which are what we were talking about this morning about protective factors. The more that I can make the environment helpful, the better it's going to be. Sensitive periods for intervention, and considering where your person is or where that child is in their attachment journey. We're struggling. I know, I don't know why. So what are the strategies of care with NAS babies? And I think we're running on time. I have 15 minutes, correct? 20. Challenges in nursing with NAS. frustration, helplessness, and I'm going to expand this not just in nursing. We're going to talk about social work. We're going to talk about physical therapy. We're going to talk about physicians. We're going to talk about everybody who is involved with this population, family side or infant side, over empathy, under empathy. Sometimes I just want to throw my shoe across the room. You know when I want to throw my shoe across the room more than anything? When we've been through this a million times and I'm tired, and yesterday I got home and the AC broke and I have to call the guy and he's going to tell me that it costs $600 to fix it, that's when I want to just throw my shoe across the room. You're a human being. Under empathy is expected. You need to watch your internal functioning so you can be an effective caretaker. The over empathy, come on. You don't take these people home with you. Okay? I know people that would just take a baby out with them if they could. They're not kittens. Communication problems, being able to communicate with someone reasonably. What is the definition of someone who is in an impaired emotional state? Unreasonable. So when I used to walk into the emergency room as a student and they look at me and they go like, Dr. Perez, they're just unreasonable. And I go, really? No crap, Sherlock? Yes, they are inherently unreasonable. Reasoning is hard with them. Understanding the issues, knowledge. Sometimes we really don't understand these things, but we're afraid to admit it, which is why it's so great that you're all here today, to get information, to try to understand more and more about a situation so you can become proficient in it. Training and education, unclear policies and procedures. Come on, who knows a hospital that doesn't have unclear policies and procedures? We're MACNet, and we still have unclear policies and procedures. How was it that I was exactly supposed to do this? Collaboration or lack thereof. Maybe you're tired. Have you ever heard that nurses eat their young? Reactivity or acting out, patience, burnout, overwork. If you have attachment issues yourself, what's the odds that you'll be able to treat someone with attachment issues? Have you ever heard with professionals, I've been through this, so I know what you're going through. Do you want me to give you an educational tool for those people? Slap them. It is the stupidest thing I've ever heard. Just because you've gone through something, that doesn't make you proficient or a professional to treat someone with it. Have you ever heard that shrinks have shrinks? I have a shrink. I've been in therapy for 20 years. So I don't get my crap involved with your crap when you're sitting in my couch. Because we all have crap. But remember, attachment is always possible. There is a silver lining. Even for maltreated children, emotional attachment is not automatic. It develops over time, so you have to be patient. And sometimes it takes a lifetime. Sometimes you have to go through 3 caretakers, 5 therapists, 3 divorces, 3 jail stints, 5 DUIs. Attachment is based on the primary caregiver. Remember, it doesn't have to be mom or dad is the primary caregiver. Bonds are indiscriminate for the first 3 months. So if you are in a setting where you're seeing really young infants, if you're in the NICU, for example, who has the ability to form rooted attachment with that child? The nurse. The nurse! And they go home and they cry with a lot of feeling, and I understand why. Because this baby has left the building and they have no idea what's going to happen next. By the way, should not be Facebooking with your patients. Don't Facebook with your patients. They are patients. okay? You were going to clap about that. Actually, don't Facebook with your kid. Please. I'm going to clap to myself about that. Okay. Good enough parenting. Winnicott told us in Object Relations that all we need is good enough parenting. Do you have to be a perfect parent? Can you be a perfect parent? Nah. No. Don't worry. Everybody will screw them up in their own way. Keeps me in business. I'll keep taking those safaris. Okay. Good enough parenting is all we need. That's all we need. You just have to be good enough. Stop putting so much pressure on yourself. Stop putting so much pressure on the people that you're trying to teach. Just teach them what they can do and what they're capable of doing. All we need it to be is good enough. Corrective emotional experiences. You can provide those for people. Me, as a therapist, anyone who intervenes, a teacher. How many people have heard about a teacher that changed someone's life? I used to have this teacher. Or someone in college even. It can go that long before something where you do a corrective emotional experience. No one ever answered the phone when you were a kid or checked on you during Thanksgiving? You know what? I will do that for you. I can do that. I'm not going to be like everybody else. Pay attention to corrective emotional experiences. Quality is more important than quantity. It implies attunement. Things to remember about attachment. It is important to engage in lively social interactions. Remember the cloth monkey. Respond to the baby's signals consistently. Consistently. They're like little dogs. If the dog pees on the floor and you wait 10 minutes to whack it in the face, will he get it? They're like little dogs. It's okay. People don't like that when I say in my therapy room either. Presence of attachment is different than the quality of attachment. Although insecure avoidance is not optimal, it can be adaptive. It's okay if someone's insecurely attached. You know what? Because if they go home and I have to send them home to chaos, I want them to not attach to everybody. It's the protective factors. I want them to make sure that they're suspicious about everybody that walks into their household to buy drugs. Because it's probably not a good idea for them to trust them. So it's okay. I have to consider what environment are they living with so I can make those interventions appropriately. There's no evidence that maltreatment leads to RAD and or other psychiatric disorders. Again, trauma is how the person reacts to it, which is what we were told this morning. In fact, there's a finding that sexual abuse is not traumatic for everybody. Social policy really hates that one.
The lack of trauma can be traumatizing for a girl who's in a family where every other girl in the family was sexually abused.
Yes, right. That could be the trauma. Why them and not me? What made them special? So it's important to think about these things. Just because that would be traumatic for you, that doesn't mean that it was traumatic for them. So stop making assumptions. How to proceed, stepwise process. This is the best advice I can give you. Have a clear protocol that is yours or one that you share interdisciplinarily or within your institution that is understood by all involved in the treatment. Remember, consistency. It can be different people, but you all have to be doing the same thing. Even if you're dealing with the mothers and you're trying to correct their behavior, you have to be consistent and everybody has to be doing the same thing. The moment that you break that sequence, you know what's going to happen? There's a hole. And what are they used to doing as addicts? Sneak, 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 sneak. So that's really important to think about. Don't change the system. Be consistent. If it's not clear, meet together. Clear roles of all involved in the treatment. Frequent huddles. Frequent conversations with other institutions about how we're going to handle this issue. Clear notes so someone can pick up the chart or you send a note to a collaborator of yours. If you're working with a psychiatrist or with an agency, by God, it's the age and day of email. Email them and tell them this is what we did. This is where we're at. Be clear and realistic objectives. Infant versus families. Decide where you're going to intervene. And really think about what can be realistically accomplished. Acknowledge and accept that you're already starting in a bad place. So make sure that you understand the degree of the problem and that you are aware of what's treatable versus untreatable. It's important to identify a potential primary caregiver. That's where they're going to go and focus on them, whether you're teaching or modeling. Forget about teaching everybody in the room. Look, if mom is not very perceptive, check the boxes and teach grandma. You know, pick the person who's in the room that is going to be the most receptive to what you're saying. Make every interaction count, quality over versus quantity. Remember the corrective emotional experience. Don't underestimate modeling behavior. Touching, rocking, making soothing noises. Most people can mimic behavior, okay? This is why 5-year-olds imitate so well. So think, 5, developmental level. If you do these things yourself, rather than telling them and screaming at them or complaining about them, they may start mimicking you. Things not to do. Don't focus on the things you can't fix. Persisting on teaching a parent that is not receptive. Unless you're banging yourself against that wall and want to drop dead, I would suggest don't do that. Perceived system shortcomings, DCS not doing their job. Great, we hear you. Congratulations. What do you want, a medal? It is what it is. Do what you can. Model for the agencies as well. Those agencies, talk to them. Be open in communication. Don't blur the boundaries. Again, the Facebook thing. Don't deviate from protocols because it interferes with consistency. And remember that what happens in the future are things that you can't control. Transference and countertransference, which we already talked about. Don't act out dynamics from previous experiences. Don't engage in dynamics unconsciously. Be self-observant as a caretaker. Identify with the situation is not going to really help every time, and try to keep your prejudices in check. Be clear about treatment goals. Clear understanding of policies and procedures. There's policies and procedures in place for a reason. Improve your knowledge of the specific population. Increase coworker administration and interdisciplinary support, increase communication skills, accept and understand limitations, which are very important. Don't send someone to treatment if you know they're not going to be able to get it. It's easy to give everybody a referral number, but that doesn't mean that that's the right thing that they should do or that they can even do it. Ask for help. Teamwork, people. Be unbiased. Have an unbiased approach. Not every addict is the same. And increase debriefing opportunities within each other when you're frustrated.